Uh, uh, Recently, I'm completing my master's in clinical counseling, preparing to test. Um, yeah, I don't think I've met either of you in person.
Well, my background as far as clinical, I worked um, in residential treatment services and specifically with youth for 10 years and then moved to the state. I've done various jobs here. I came to the state as a at-risk youth coordinator back in the Beckett Bill days when that first came out. Um, and then managed lots of contracts across the state. And now the BHSO work is on my plate. Anyway, so good we have some kind of background here. So let's get going. So evidently the recommendation education campaign to clarify state requirements related to intake assessments that must be administered prior to providing different types of behavioral health services. So explain the system, policy, or process change proposed. What are we proposing to do? I know that the goal is to be able to get people in services sooner than later. And I think from my perspective, I think there's a little bit of a misunderstanding about what has to be done before somebody can access services. I know in talking to SUDISA, she's been frustrated. You know, a doctor can diagnose somebody and then make up, do the prescription or prescribing for medications. Um, so that's one way people access services. And then people go into a withdrawal management program. They don't get it. They get assessed obviously for that. Or like the methadone programs, they get that assessment related to withdrawal and being on methadone or to get on methadone. And then for outpatient, I think people do get a full assessment before they go into outpatient, but it, you guys will probably have to remind me because it's been a while, but it seems like you have a couple visits to get that full assessment completed and get your treatment plan done. And then for residential, back in the olden days, when I did residential treatment, we had a screening that we would do prior to the person coming to the facility so that we had a pretty good idea that they would qualify. And then if they were a managed care, you know, they had private insurance, then we did the full assessment right on the spot and then got the approval from managed care and admitted them. And if they were a DASA funded back in the olden days, we would just admit them and then get the assessment done within the first few days. I don't know. For me, the standard was get it done the first day they got there, but we had a week or so to get it done and then develop the treatment plan. But it seems like we should be able to do some sort of assessment, a quick, like we did a pre-assessment when people would call in to decide if they should come to the residential program. But I don't know. That's just my perspective. So the system.
Insurance. Insurance is the problem to everybody's issues. And so it's I would agree, it's very similar. So we'll, like for our intake, we got to make sure that they have insurance and we have to make sure that all the releases are in play and all the forms are filled out and all the pre-assessment paperwork. And then so that all gets done. Then they schedule once they've been approved that their insurance is billable. And then they get on a schedule for an assessment. Once the assessment's completed, then they got to do their intake. Once the intake's, that's when they do their initial treatment plan. And now you're technically a client. It's a long, drawn out process. And you lose people along the way.
So private insurance.
Well, it's insurance.
Like Medicaid is, what's that?
No, I was just saying it's insurance period because even people come in and they don't have their Medicaid or their Medicare and they don't know how to go about getting it.
Mm-hmm. And then there's the other step that's even after they fill out paperwork, so find out they don't have insurance, then we have to make sure they got insurance. I mean, because realistically, so I know I do a lot of screenings for the drug court program, the California County Drug Court, and they just really need to know that there's a problem. I can go in and screen somebody with 11 diagnostic criteria and check the box. Yeah, they're going to meet criteria for needing treatment, and that can get them in out of custody and into the like admitted into the drug court program. And then from that point, I can do a real assessment, a full assessment on somebody. But I always believe that you can look at the diagnostic criteria and pretty much gauge if somebody's going to need treatment or not off of 11 questions.
So
Yeah,
I know
there's
when
a
I did,
difference of identifying that they need treatment and then developing that treatment plan. And that's where you want that full assessment.
Right.
Sorry, Dominique.
so I know when I worked, when I did drug court, once they identify that they have a problem, they get into drug court, but you still have to do the assessment.
Mm-hmm.
And so
Yes.
the assessment is done before they begin treatment. But you run in, even in drug court, you still run into the problem of them completing the assessment in a timely
Mm-hmm.
fashion. Because I've had people who were technically in drug court for like 2.5, 3 weeks that I was running behind trying to schedule their assessment.
Right.
And then the other problem is if they qualify for inpatient care, being able to get them the space to get into inpatient so that they can come back to drug court. It seems like there should be an expert to identify kind of the initial level of care. We should be able to use expert to get patients into whether it is inpatient or IOP or OP. And then once they get into that, and once the expert has been identified, that's where insurance should be become a part of the process. At least in my head.
So we kind of have a little bit of some of the issues that we've noticed. So what do we think the process should be? Do that expert and then check insurance and then complete the assessment? Is that the suggestion?
Yeah, if we can identify where the level of care is needed and the screening of if somebody needs treatment. I mean, I understand the need for the full evaluation, but that should allow somebody into the client and in groups. Or like if you're looking at an outpatient, you're getting them in, you're meeting them where they're at, and you're getting them in rather than them kind of falling off the radar. And, I mean, I'm pretty sure you guys know that if somebody comes into treatment today and they want help, we need to be there to help them today because tomorrow they're not, it may or may not be there. And so I truly believe the faster we can get them in and get them into group settings, the better. And complete the real assessment with treatment plan as they're already kind of engaged in treatment services. In my perfect world, that would be amazing.
And I agree. I think part of the responsibility to ensure insurance is there I think there has to be a step to help the patient with that as well. That I guess the struggle is it's more work for the clinician, but I think it's also a necessary step to include to ensure that the patient stays engaged.
And I think a lot of the lapses in the whole insurance thing is a lot of it has to do with getting incarcerated and going into jails and coming out, and now their insurance is no longer active. And we all run into the same kind of people that are in and out of custody. When they come out, their insurance has now been denied, and you have to restart it. If that piece was to never happen, I don't think a lot of these people would actually lose insurance ever, except for maybe their updates on their insurance that they have to do. What is it, annually? I'm not too sure.
I think that when people go into the jail, I think their Medicaid isn't canceled or shut off. It's suspended. And I would need to double check, but I thought that we had something that they wouldn't even suspend it for the first 30 days. I don't know if Brianna, if you're listening in, if you can confirm that, but maybe that's something for me. I'll double check on that.
But I know that that's a huge piece when people get out of custody, and then now we got to get their insurance back up and activated. And the other flip side about that is when they're in custody, it's the easiest time to assess them because they're not going anywhere, but they don't have insurance at the time.
There are the jail services programs. I don't know if they're in every single jail, but they should be able to help with assessments. I don't know if that's happening.
There we have some CJTA funding, but the other flip side about that is like you have to apply. Every agency has to apply to get access to it. Not every agency is approved.
Right, I understand
So
about CJTA, but also there is jail services, jail transition services. And so we do have people going into the jails that they do help to get assessments, help with that insurance issue, help to transition that person out so that they don't end up right back in jail and that they do get connected to services. Again, I know that probably every single jail doesn't have somebody there 24/7, but I think all but maybe 3 or 4 of the jails across the state do have somebody coming in there sometime. Um, so that might be something to look at or
okay.
ask about in your local jail. Because
Yeah, I know in Pierce County it's contracted,
yes, and
and so
um,
it's based on how they can if they keep it staffed, basically.
right. So staffing's an issue for everyone everywhere. Come on.
Yes, absolutely.
So that is a problem, but there is funding out there and there should be jail transition services available. So hopefully, if you don't know about it, ask in your region who their transition services folks are so that you can connect up with them and have them helping you with your clients that might be incarcerated, suspended.
But so like when I said before, I created a screening tool when I would go into custody, and a lot of times it kind of outlined everything that drug court or the mental health sentencing alternatives or the drug offender sentencing alternative programs, like all those programs really need is, yes, I have proof that there's a history of substance use or mental health issues, and a lot of times that gives them enough to where they can release this person knowing that they will accept them once they're actually engaged in services. And I think a lot of the pieces to the puzzle of getting people in sooner has a lot to do with the screening tools and not necessarily needing the full evaluation. I always felt like that was the piece needing, you have to have the diagnosis in order to bill. And so that always kind of hit the brakes on people getting into services quickly.
But like I mentioned before, you can diagnose without doing a full-blown assessment. And doctors do it all the time. They assess, like you were saying, off of a few criteria. So we know um, take a look at the criteria, diagnose, but it's a treatment plan that needs that full assessment. If you don't have a full assessment, then you can't do the treatment plan. So diagnosing is a part of it. And that should help get people in the door, in my mind. And
So
all
where
the
I'm at,
screaming is screaming.
the hospital, the doctor diagnosis is typically a rule out because they don't ask all the questions
Mm-hmm.
to formulate the diagnosis. Uh, the doctor asks, they tend to ask very basic usage questions and formulate it based on that. So that doesn't provide a level of care. And and this is just my personal opinion. That's part of the struggle with medical providers providing MOUD treatment because they're not the actual issue isn't being addressed.
Right. Sometimes those
So
people, even though they're getting that MOUD, they need a residential program or they need an intensive outpatient, not just the
right, they need
office
counseling, they
based.
need they need assistance in again the other dimensions that impact their usage. So that's always
Oh
been
yeah.
a bit of a struggle for me because that's where even though I recognize the assessment is lengthy and extensive, if you are actually in a decent program, all of those things are going to assist the client in extending their recovery efforts.
And I think that
So I don't
screening can help to determine level of care that's needed, um, depending on what screening tool you're using. I don't know how much time we have left. I'm guessing it's not that much longer, but
It
um,
goes quick.
yes, it does. When I started seeing this, it's like, this isn't going to get done in a half an hour. And
No.
this is just a jumbled mess that I have here, but it's just, we have our comments and we can continue work on that. Um,
and I also think one of the looking at the background, I think part of the issue is always that patients can get different aspects of treatment, i.e., they can get their assessment, they can get an expert, they can get into drug court, but in transitioning from different agencies, because as we know, a lot of our population is very nomadic. They are unable to get into treatment services at other agencies. So I think there has to be some uniformity where they're able to get in if they've got an assessment from one place or they've got a referral from one place, they should be able to get into a treatment program somewhere else with someone else.
I think the heart, and I don't want to say this out loud, but I'm going to anyway. I think the majority, I think most people will be like, okay, but it's the organizations that want to be able to bill for the assessment.
But absolutely, I 100. That's what I run into right now, and that's why I think there's going to have to be a policy created that ensures that it's patient care over financial gain.
I couldn't agree more. Unfortunately, when you work for organizations, like I said, I was part of the management team at the Cowlitz Indian Tribe, and that was one place that we accepted other assessments. Where I'm at currently, we require another evaluation, even if this assessment was completed 5 days prior.
Do you do another full assessment, or do you just go over the assessment that you have in hand with the client and make any updates? I mean,
They
5 days ago,
require
you shouldn't have to update it.
You shouldn't have to. You're absolutely correct. But it's a full assessment because they want it how they want it. And
Yeah.
so and that's where I think the uniformity piece really comes in, because everybody's systems are built different. All of our EHR systems are all different. And I think that's one of the big things that I'm hoping that the state comes through with and says everybody needs to utilize this EHR system, because I think at that point it would change a lot of the issues to where that assessment will just come exactly how you need it from another agency.
And what I'll also say to that is, because I agree, and some of that comes from the clinician capability, right? Because it's about capturing all of the information. And that's, again, this is where my bias comes in, because I struggle with a lot of other disciplines being given the ability to conduct the assessments without really understanding why or what the how all of the information pulls together and how it's important and how it impacts treatment.
I feel you on that. That's why I went back and got my master's degree, because I was kind of tired of people looking down on SUD as a throwaway program.
Yeah.
Well, we're
Yeah.
just
Me
not
too. Me too,
educated and we
sir.
don't know
Me
what we're
too.
doing, really. That's the thinking.
Yeah. And now
We're
I
all
can say,
just a bunch
well,
of we're all just a bunch of addicts that
mhm.
now we're counselors. That's what I heard when I was first coming into the field.
Oh yes. It was one of the driving
Uneducated
forces.
field. Yeah.
Yeah. I was like, well, I can match that with you now. And I can also say that I'm duly licensed. So what can you say, Miss Mental Health Provider?
Yes. Good job. Um, so I'll just say historically, there was a, a Hargrove bill, I think back in maybe 2003 or somewhere 2003 to 2005. And in that Hargrove bill, we did a, a group of people met and we reviewed. There was the goal that you had to have a standardized assessment and a screening tool. And so that's where the GAIN SS came in, the requirement to use that. But the people that we had as consultants for the assessment recommended that we not have a statewide required assessment. They recommended that we have a list of required elements in the assessment, and they recommended that we use tip 42 for the sort of the guidelines for those elements that would be required in an assessment. So that's why we don't have a statewide required assessment. So sorry for my part in that, but we're just following the recommendations. And there was a lot of pushback from um, agencies and yeah, about the assessment. There was a lot of, well, there was some loud voices who wanted us to use the GAIN assessment as well as the GAIN screening tool. We did pick the GAIN screening tool because it screened youth and adults and screened for mental health and substance use disorder. And we could get it for $100 for 5 years. It was low cost, it was easy to use and all of those things, but that's why we don't have a statewide assessment. But I think if the mood is changed in the state and people support that and push on the legislative level for that, um, I think more power to you all for doing that.
I think it would be amazing to have more of a black and white rather than a lot of gray mixed in, because the requirements for the state assessment aren't minimal, but they're very minimal. So I've seen assessments that meet state criteria that are a page and a half long. I've seen assessments like my previous job where it was like a book that we had to write because it was very, very detailed. And we got a lot of really good comments on how precise our assessments were, but they took 3 hours to complete.
Yeah. And then you can do a good treatment plan, but it does take time.
Yeah, when you have somebody that's kind of not really wanting to sit there for 3 hours, that's not feeling the greatest, it's really difficult. And then it's almost
Yeah.
like torture.
Yeah. I try to break them up when somebody's, just getting there and not feeling so well. But you can't always do that either, depending on your
Yeah.
caseload.
Yes.
Or I'm surprised you're not getting called back in. Doesn't this meeting end at
I think it ends at
10?
10:30.
Oh, okay. Okay. So we have more time to keep going. I don't know, my little brain in my day, it was ending at 10. Anyways, okay, so we have in what I've written down, I think we have a lot of background too, but not the policy or procedure, but we have some stuff. I don't know, anticipated impact of recommendation, explain some of the, um, well, to have a standardized EHR requirement and a standardized assessment requirement, there would be a pushback. Um,
Oh, I'm sure. But isn't the state trying to put together a free EHR system?
yeah, because there are a
Epic,
lot
I
of mom
heard.
and pop shops that don't have EHR yet. And so we are, yes. And so that's a possible opportunity.
Well, I've heard nothing but amazing things about the Epic. I mean, I'm working off of Avatar where I'm at right now. In my previous job, I was working off of the tribe's EHR system that was developed in Vietnam. So, and I'm not joking.
Yeah, if the state would push that, everybody has to use the same system. That would be great. But
People are already in contracts and there's already been established electronic health records. It's just, it doesn't make sense to me that, the idea of going electronic health records is a great idea, but they don't all talk to each other. So it still
that's what
doesn't make any sense to me.
that's one of the things I was just going to say is whatever, even if they don't use the same one, they need to be interoperable so that they
Mm-hmm.
can talk to each other and that. But I think I'm not a computer person, but the computer person that I talked to of late said there's a way to have a intermediate thing where you're, even if yours doesn't normally talk to another one, there's a way to take it through a gateway. She explained it like you're ordering food at a restaurant and the waiter takes your order and takes it to the kitchen and then it's cooked and they bring it back. And so there's something in there. I don't, like I said, I'm not a computer person, but there's a way to link them even though they don't normally talk to each other, because you don't normally talk to the chef at the restaurant, right? But you still get your
Right.
food. And so that's how she explained it in dumbed down terms for me. But
No, I mean at that point, it's no different than doing written charts. If they're not speaking to each other and we're not able to access other agencies' information when needed,
mhm. Yeah,
it's no different than written charts, in my opinion.
yeah. I don't know. I worked in the olden days where our charts were all written. We weren't all electronic yet by the time I left. They were just transitioning. Thank goodness. Um, I don't know. I think some of this background that would take more than just off the cuff. the need, we kind of have that up there. Proposed recommendation. Our recommendation is standardizing, right?
You know, I heard a lot of people when I first jumped into this whole thing, I was absolutely petrified because there was a lot of the talk was everybody should be able to do a SUD assessment. And I'm like, whoa, pump your brakes on that. That's terrifying. But it got me thinking in the sense of, okay, so if you want a mental health provider or a doctor to be able to assess a substance use, then there needs to be crossover where SUD can at least assess the mental health symptoms to where maybe we're not treating each other's patients, but we're assessing and then saying, hey, look, here's some of the symptoms that we're finding. SUD treat SUD, mental health treat mental health. But if it's going to go one way, there should be reciprocity that goes across. Maybe there's a little bit more training, because I still believe even somebody with a master's degree should be trained in SUD, but then it needs to go across the board as well. And I mean, SUD counselors, they diagnose. It's no different than diagnose a mental health disorder. You
Right.
find criteria and you put down your recommendations, and you rule out what you think it could potentially be. Now, if we're going to go one way, it needs to be both ways, in my opinion.
Yeah, I think there is a big push for more um, duly capable at the least programs, and um, duly competent is a goal. I don't know. It's hard to think that somebody would go into services like happened in the olden days and still happens, is that if you're diagnosed with substance use disorder, then that's all that is being looked at, when mental health is a big part of it. Or, you're
Absolutely.
using substances to treat your mental health symptoms, and you need some mental health support in that respect. And that has to be provided at one time together, not sending you to extra meetings so that you can get your mental health needs met.
Right.
But anyways, everyone in the field knows these problems are out there. And I'm sure they haven't gone away since I was working in the field. Um, Fiscal impact, I don't know. I think somebody else might have to come up with that.
Did you say
Cool.
fiscal impact?
Mm-hmm. Fiscal or financial impact, whatever, it's fiscal. So, um,
Training time, really. I mean, I don't know.
funding for training. Well, HCA's putting out all these ASAM trainings, so hopefully you all get signed up for them if you haven't already. Have you gotten the notices about them?
I've gotten the notices. I haven't been able to sign up yet. My schedule is crazy.
I can relate.
I'm yeah, and I want to go and just buy a book, but I'm trying to get my agency just to buy me the new ASAM, but it takes forever to get them to do anything.
Well, we'll have ASAM trainings going on pretty consistently through January of 26 when we transition to the fourth edition of the criteria. So you have time to get your trainings. If you can find time for at least the first one, it's only 4 hours, and that just gives you an overview of the changes in the fourth edition criteria. So I would encourage that. It's a little easier to find 4 hours than it is to find 2 days, or
Yeah.
the other training is, so there's one that's 2 days and there's one that's 5 days, 2 hours each, and it comes with some um, consultation support after the training, I think. Anyway, so funding for training.
realistically, the whole assessment's going to have to be updated and changed for every agency moving forward. And so, I mean, it's going to, I mean, there's a huge impact there for anybody that's going to be developing, and that's why I always wish that there was a standardized state assessment that was like, look, this is what we're using, get used to it, and everybody can learn and the same thing. Because looking at it through an EHR type of lens and more of like a management lens that I was in, all your templates in EHR are now going to have to be changed. Everything, your treatment plans, everything is going to have to be changed.
So now's a good time to change and make everybody use the same assessment.
Exactly. I mean,
And
literally
screening
everybody's going
tool.
through a change. And I wish they would make it like a co-occurring assessment to where your mental health and your SUD are all combined, because that's another thing that irritates me, because I do mostly mental health now, is watching people have to go through a SUD evaluation and then a mental health evaluation to get, and we're all asking the same questions. We're just asking them through a different lens. And so these people that have to jump through the hoops of getting both done are getting bombarded with the same questions over and over and over again to get the same, to get two completely different diagnoses.
Mm, plus two. Mm, gonna have some money for everybody to move to the same EHR. um, I don't know. I don't know where we're at. Well, we know there's problems. We're all in agreement with that for sure.
Oh, yes.
Dominique, did you have any others comments or suggestions or something that I should make sure I note down on this convoluted mess I have here?
No, I think Dallas did a great job. I'm kind of forced. That's why you got so many thumbs up from me, um, because I agreed with a lot of kind of what was put out.
Okay. All right. I don't know what else to put on here.
I think we got enough complaints on there.
Well, we did a great job with complaining, didn't we?
Oh, yes. That's the easy part.
Mm-hmm. Well, this is a great opportunity for a good system shift. Having hopefully we continue to have legislative support after the first of the year, when we get a new governor. But there's good momentum right now, anyway, to make some of these changes. Mhm.
I really think systematically, like if we're all learning the same assessments and we're all learning how to diagnose and do things the same way, it makes transitioning so much easier, because we work in a field where people move around just like the clients. And if the clients are getting the same kind of assessments and they know what they're looking to when they jump from one place to one place, or when staff jump from one place to another place, like it I've always kind of sat there and was like, why don't we have the same assessment? Because if I was a client, I would definitely be going to the place that it took 20 minutes to get an assessment done. I wouldn't go sit for 3 hours.
Exactly. And I agree. I think having that, them knowing that there's going to be that consistency all the way across the board will minimize some of the picking, as well as just encourage, like, once they recognize, like, it is what it is, this is what it's going to be, I can go in, I'll get it done. And I think it would create more of the stability that is the piece that, is the struggle anyway.
It'd make life for the auditors a lot easier too.
That's for sure.
And I would love that, because that means they would be easier on us.
Yes.
Yeah, I would make things streamlined all over. I mean, for the clients, it would be easier. For the staff, as you hop from one agency to the next, would make it easier. Financially, probably lessen the number of repeated assessments, and which takes
Mhm.
up clinician time, and is
It
off-putting to
also
the
make training
clients that we
easier.
see. Yep, training. I mean, all of it. Well,
Absolutely. And then being able to, like, I always in my mind envision, because when I was building templates at my old job, I wanted to build the assessment, but I wanted to have like a click box there to where, like, are we gaining your background information, and then be able to click, are we moving forward with the SUD assessment, mental health assessment, and to where you can take the background data, all your collateral information, and then go, okay, we already collected it. Well, now we're going to finish the mental health evaluation piece. It's since somebody already did the SUD, to where we're not having to rehash the same stuff over and over again and just take time away. And then we're talking about really streamlining if we're able to just take that and just move forward. I mean, your assessments from 2 hours are down to an hour or less when you've already got your background information already put in. And you can update as needed. Oh, I moved from this place. Yeah, my old boss. Ruth, do you remember Sybil Iverson?
hmm.
So she's been blowing me up on coming and working at the state. And I'm like, I can't right now. Can't right now. I'm locked into HRSA and I can't go anywhere for at least another year.
Uh, got some support with your schooling.
75,000.
Yeah, we don't want to lose that.
No.
Yep, I got some help too with mine. Didn't pay for everything, but paid for a good chunk.
Well, I think Washington did their own little thing after I already signed up with all through the HRSA stuff. And I was like, dang it, I should have just stuck with that, because I think that you can use at the state too.
Mm. Been a while since I did financial aid stuff, thankfully. Well, I'm not sure what more we can throw onto this. It needs some organization, but otherwise we have a lot of information there. Some good ideas. I wrote down your idea about that assessment. If you could pull in the data from a mental health assessment to your substance use disorder assessment instead of having to do it all from scratch, that would be great. That's a really good idea.
Well, I developed a template when I was over at the tribe that allowed it. The problem is like, again, not having like your state assessment, right? Everybody would have to kind of create something similar. So I think a lot of these pieces, I think if we had a state operated assessment, when there's any updates, the state can just come in and update, say, hey, this is the new form you need, this is the new version. And it would, I think it would save a lot of time and money. It would save insurance, I know, a lot of money.
Well, there's a lot of talk. Well, there's a lot of funding right now being put into computer stuff, electronic stuff, getting interoperable systems related to the crisis system. And so all those interoperable systems, as far as I understand, which again, I'm not a computer person, there's ways to make them talk in with different systems and with different elements, like we're looking at bed registry or crisis plans and the health directive for mental health. So we're looking at those kind of pieces. So why not be able to get a assessment that could be accessed by other people? So you just, if the person said, oh, I just had an assessment last week, you should be able to go in the system and pull it down to your system. But
and go right to an admit. And so that person's in services immediately. Because that's the other part is like, you know, you have all these competing agencies working against each other rather than working with each other, which is absolutely asinine because we're not here to make money, even though you have to make money as an agency to keep your doors open. We're here for the clients, but everybody it just bugs me. Because when somebody gets discharged, I mean, I wish the agencies would be able to work together and say, look, here's the assessment, here's the discharge summary, this person stopped coming. Cool, get them into services as fast as possible. But we all know that agencies don't work together like that.
sadly, they don't. And there's not good transition from residential to outpatient either.
No.
Especially in the adult system. I think it maybe is a little bit better in the youth system, but it's not good either in either system.
Well, in my little community, we're pretty lucky. My wife actually runs the family health center, inpatient center. So, and all of our agencies, for the most part, we're all on pretty good terms. So we try to work together pretty well, but
Oh, good.
it's not the clinicians, it's the management that don't see eye to eye with everything.
Yeah.
Most of the clinicians have worked in every agency around our area.
So that's good. And you know each other. So that helps having
Yes.
those relationships. I found that too when I was working in the field. The relationships were the best.
I truly believe that's the key to being a good clinician is having good relationships with other agencies so you can work together to help the person.
Yep. Most definitely. And when you know the different programs, you know who's a good fit for the client you have in front of you if they're not a good fit at your agency or if they need to move to another level of care.
Oh yeah. I would never admit to it if my boss was standing here, but I refer people to other agencies all the time.
Well, and if that's what's best for them, that's the best thing to do.
Yes. Yes. Yeah, I would lie up and down, be like, never did. I never refer anywhere else.
Okay, it looks like we're supposed to wrap things up because we're going to be moving to the other group here pretty soon. I appreciate you all, Dallas and Dominique, for your comments and support in this. And clearly there's more work that needs to be done on it. Thank you.